Well, thank you very much and good afternoon. So, two very entertaining speakers. I'm not sure how much better I'm going to do here, but I'll give it a shot. And we're going to talk about nuclear medicine approaches for detecting, we're talking about myocardial ischemia here, and I do want to focus on that a bit. These are my disclosures, nothing of relevance, but just here they are. But I do want to mention, at least from a state's perspective, I have to admit I don't know as much about Brazil, we're seeing an evolving evaluation of the patient with chest pain and how much of it's due to atherosclerosis. And we also see an evolution of our technologies. I mean, obviously, what do we want to do? We want to diagnose a disease, we want to assign prognosis, and we want to decide a therapy based on that. But we have all these different tools, starting with the anatomy. As we talked about, the calcification presence for atherosclerosis is a reclusive disease. We now have advanced methods for plaque characterization with CT that are helping us. And then what's the biological relevance of what we find? We now know about the pan-inflammation of atherosclerosis. Well, how does that play a role? We now know there are metabolic changes with that ischemia, and ultimately edema and scar. And lastly, there are physiologic manifestations from these biologic manifestations in terms of perfusion, function, and electrocardiographic, as we've already heard. But as I mentioned, the disease is changing in front of our eyes. I mean, I've been practicing, like many people in the room, a long enough time to see. We're seeing a decreased prevalence of obstructive coronary artery disease. We're seeing a decreased admission for ST elevation MI. We're seeing an increased incidence of type 2 MIs. And much of this is being driven by the presence of cardiometabolic disease and this pan-inflammation that occurs, and ultimately that affects the microvasculature. And that's going to impact our ability to detect disease based on the technologies that we use. All right, so this is my cartoon of the ischemic cascade. You've seen two, this is mine. And what I've done a little bit differently is I've tied some of the imaging approaches to it. And I do want to make one point. When we look at impaired perfusion, we may not be looking at ischemia. We are looking at impaired vasodilator function. And it may not lead to an imbalance in oxygen supply and demand. None of those occur until we start moving up the chain. So this will become important as I go through the talk, but you want to be thinking about what am I seeing with this parameter when I stress somebody, because it may not mean that there's ischemia per se. It may not mean there's occlusive coronary disease. It may mean that there's a totally different disease ongoing. So here's a case from our laboratory. SPECT is still the mainstay in our country as it is in yours for nuclear imaging. And this is a 50-year-old male with chest pain, hypertension. He has known coronary disease, and he also has acute on chronic kidney disease. So we already know he has disease, and this is where we use it. We don't use it as much for patients with a low pretest likelihood of disease. We probably shouldn't be doing imaging there. But here's the case. He came in with non-STEMI. And as we already heard about the importance of electrical stress ECG, I agree with that. But we don't stress people much anymore. When I started stressing people 30 years ago, 90% of people we had in the lab we stressed. We now do 10% in the lab. That's the Americans, they can't exercise. And so we are doing regadenoson perfusion imaging, and that's what you see here. And so what you have here is a stress study on the top, the rest study on the bottom, their attenuation corrected, and I think you can appreciate the reduction in relative blood flow in the apex that reverses. This is the classic ischemia you see in the bullseye. It's hard to read, but there's a slight decrease in function as well. So it's a classic case of myocardial ischemia. We know it's a high-risk study, and this is, again, as I mentioned, classic. And I'm not going to spend a lot of time on the SPECT studies because we're doing less of them, still do a lot, but we still use them when we use them appropriately. And this is a study from the Cleveland Clinic, which shows that when you use it in a way that makes sense, meaning that you have a scan that puts you in a low, intermediate, or high risk based on the presence or absence of disease, the extent and severity of disease, look what happens. What they found was if you looked at patients either with pharmacologic or with exercise, the referral for angiography changes pretty dramatically. When the scans are negative, they don't go. When they're intermediate to high, they do go. But more importantly, if you look at the other downstream effects, revascularization, pharmacologic angiographic revascularization, and so on, you see a marked difference in terms of those. So it's driving the therapies, and these are also driving outcomes. And again, I do want to emphasize, as was brought by the other two speakers, strong exercise capacity, patients do well. And if we don't exercise people, we lose that. But I think where we're moving in the States, we don't have as much information. But the point being is a SPEC study done well can provide you very unique information that helps you determine risk, determine what therapeutic outcome you want to do, and how the patient will do longer term. So I've kind of highlighted all of those here, but I've also mentioned that because of this, of decreased prevalence of CAD, obesity, inability to exercise, and the growth of microvascular disease, we are actually transitioning from SPEC to PET. So it's a different technology, and the advantages of PET, I'm not going to go through all the acquisition differences and so on, but we have better spatial resolution, we have better image contrast, we can do things dynamically, so we can quantify blood flow in mLs per gram per minute, not in terms of relative differences. We can look at stress function, not post-stress function, and because of these quantitative capabilities, we can quantify the blood flow. We take advantage of short half-life tracers that make for rapid studies and also improve radiation exposure profiles. Here's one study of an example where we have a normal SPECT on top, clearly an abnormal PET on the bottom, just showing the imaging capabilities of the technologies. And in fact, the perfusion tracers that we have are better perfusion tracers than we have with SPECT. If we look at broadly how accurate is the technology, PET, this is a pooled analysis done a while back, but it shows you that you had sensitivities and specificity of about 90–88%, and they are superior to SPECT. I'll guarantee you specificity and sensitivity are both going down, particularly the specificity, because of the changes in the population. So PET is probably even better now than it was, at the time of this study. But the real strength is in the quantitative capabilities. This is an example I just love. It's an old study, but it shows very nicely what quantification of blood flow can do. These are relative perfusion images with N13 ammonia, or rubidium-82, a PET tracer, showing you this very small anter-apical perfusion defect. Not real big, but not, still there. This is the quantitative blood flow now. And you can see that the stress blood flow is markedly reduced compared to the rest blood flow. With the color scale here, higher red means higher blood flow, greenish blue means low blood flow. You can see that the blood flow in absolute terms is down. And then when they did the angiogram, there's multivessel disease. And when they looked at that, they found that when they looked at this, what we call coronary flow reserve, it did a better job of picking up the multivessel disease than did the sum stress scores, the relative differences in uptake versus the quantitative blood flows in mLs per gram per minute. It also helps us prognosticate. I got this example from Marcello De Carli, who showed us here a SPECT study again that was negative, despite this patient having pretty dramatic ST changes on their exercise study, but it was negative. And the PET study showing a pretty dramatic infralateral wall perfusion abnormality, and the angiogram concurrent with that. Now you might say, why did the SPECT study miss this? You have to remember the SPECT tracers are not great perfusion tracers. They have a roll off at high blood flows. They don't track to high blood flow levels, so the ability to differentiate is not as good compared to the PET tracers. I think that's what happened here. But if you then take this data and look at the information you get, look what happens. Your ability to, when you quantify the blood flow now, and this is what they did here. If you look, the stress flows are all low in this patient, all consistent with multivessel disease. When you look at that, you add it in, you see how much better the patients do in terms of their cardiac mortality when they have a greater flow reserve. And when they have intermediate flow reserve, they do worse, and a poor flow reserve, they do much worse. And okay, that's fine, but if you integrate it now with the relative differences in ischemia, meaning based on the imaging, anterior wall down or up a little bit, and you add in the function and everything else here, you again see that as a flow reserve is impaired, the patients do worse regardless of what the relative differences are. So this quantitative capability for coronary disease is powerful, and it's being added more and more to our armamentarium. But many of our patients have chest pain but don't have occlusive coronary disease. These are two examples of patients, one of whom both have micro or vasodilator microvascular dysfunction, but for different reasons. In this patient, here's the ammonia study, these are just relative images. Here's the dynamic data during stress versus rest. You see that the stress flows are markedly reduced throughout the myocardium. They should be above 2, 2.5. In this case, you're 1.3 and whatnot. So the flow reserve's down. So their vessels aren't able to dilate. So that's why they're having chest pain. The patient to the right is different. He's having chest pain too, but it's not because of microvascular dysfunction. They can actually increase their blood flow. But because he's hypertensive and tachycardic, his rest flows are sky high. So the difference between his rest to stress is much different. His vasodilator capacity is down. He can't increase his blood flow as needed when he exercises. So it tells you how the quantitative capability helps you, whereas you'll never see this on a relative study. And we can get even more elegant than that by looking at differences in these different parameters to help guide us. So for example, if you take a patient who has a normal stress flow and a normal flow reserve, they do great. Conversely, somebody who has an abnormal stress and a reduced flow reserve, they do very poorly, but we have these intermediate groups too. These are the types of patients that have a high maximal stress, that's the yellow, but because of their high rest stress, their flow reserve is reduced, like that example I showed you before. Conversely, you have other patients who do better because their maximal flow is down some, but their flow reserve is higher because their rest flows are low. So their ability to increase their blood flow is still there. Their difference is still there because of the reduced blood flow. It's showing again how doing these quantitative measurements help us better understand where these different patients sit. Now, the biggest problem with PET, besides being expensive, is the tracers are hard to get. Rubidium-82, you need a generator. You have to get them every month. They're like $45,000 a pop and so on. So they're expensive, and that makes it difficult. And 13-ammonia, you need an on-site cyclotron. That makes it difficult. So there's a new drug coming out, F-18 flurpiridaz. Believe it or not, it's a rat poison, but it's a great blood flow tracer. And it works by, it sticks in the myocardium. It has a beautiful linearity of blood flow. And because it's F-18 labeled, it can be delivered as a unit dose, just like you would do with FDG if you were using that. And this is just the second phase 3 trial that was published last year that shows that here's a stress spec study, the stress PET study, showing you the ability to detect disease better. And overall, it performed much better than compared to SPECT. So this tracer is coming, and I think this is going to open the door to a lot more perfusion PET because people will be able to use the tracer much more easily than it is now. So the entry, if you will, the barriers to entry will be diminished tremendously. So let me close with just one of these take-home points. SPECT still works really well for detection of significant obstructive disease and risk assessment in the right patients. But the accuracy is declining. Our patients are getting bigger, they can't exercise, and there's a bunch of them that will be intermediate risk, but we're still not going to know what's the cause of their chest pain. PET offers the ability to give us a better image so it can detect occlusive disease, but because of the quantification, not just detect occlusive disease, but its extent and severity, and more importantly, detect microvascular disease that is a cause of the chest pain separate from the atherosclerosis. As I showed you, we have new tracers on the way. I think they're going to help and, again, make it easier to start doing PET. And my hope is that within the next few years, you'll be seeing PET supersede SPECT as a primary approach for looking at coronary or myocardial blood flow in a patient. And with that, I'll say thank you very much.